Hi guys, this video is about retinoblastoma. So there is a history of a 2-year-old child with whitish reflex in the left eye while taking the photographs, and there is also a history of occasional misalignment in the left eye, and on examination there was leukocoria and strabismus. So this was found to be retinoblastoma, leukocoria and strabismus. Now, coming to the definition of retinoblastoma, it is a malignant tumor arising from immature retinal neural cells that are neuroblasts. They are small, round, blue cells. Coming to the epidemiology, it is the most common primary intraocular malignant tumor of the childhood, affecting the children of 1 and 2 years. Coming to the pathogenesis, we already told that it is originating from immature retinal neural cells that are the neuroblasts. And what is the genetic basis? This goes by the mutation of RB1 tumor suppressor gene located in the long arm chromosome 13. So it is a mutation of RB1 gene. And now we have to know about Knudsen's two-hit hypothesis, which we already studied in pathology. So here they say that if the tumor is heritable, there are 2 hits. First hit is in the germ line, that is it affects all the cell, while the second hit is in the somatic cell, that is the retinal cell. So there can be non-ocular cancers also because the first hit is in the germ line, that is it affects all the cells. While the non-heritable or the sporadic thing, both the mutations first and the second occurs sporadically within the single somatic cell, that is the retinal cell. So it is unilateral and unifocal. Now coming to the growth pattern, there can be endophytic or exophytic. Endophytic means they grow into the vitreous cavity and there is a cottage cheese appearance, while exophytic means they grow into the subretinal space and there we can see exudative retinal detachment. So endophytic, cottage cheese appearance; exophytic, exudative retinal detachment. So once again, what is the Knudsen's two-hit hypothesis? In the hereditary thing, the primary hit is in the germline mutation, so it affects all the cells. And the second hit is in the somatic mutation, only the retinal cells, and hence it is getting mutated. In non-hereditary retinoblastoma, the primary and the secondary hit occurs sporadically at the same time. Now coming to the pathology, we can see undifferentiated small round cells with large hyperchromatic nuclei. And then we can see 2 types of rosettes: flexor Wittgensteiner rosettes, that is with the lumen, and Homer-Reiter rosettes, that is without the lumen. And dystrophic calcification is pathognomic and is seen in 75% of the cases. Coming to the clinical features, we divide the clinical features as quiescent stage, glaucomatous stage, extraocular extension and distant metastasis. So coming to the quiescent stage, here we can see leukocoria, strabismus and nystagmus. And glaucomatous stage, we can see increased IOP that can be due to neovascularization or the angle block. And there can be corneal haze, congestion and ophthalmos. So we can see a red eye. It will be a painful red eye. Now, extraocular extension means the tumor bursts through the sclera, so it will come out and they rapidly grow and fungate as orbital mass with proptosis. Distant metastasis means it can be lymphatic, direct or hematological. Lymphatic can go to preauricular and cervical nodes, direct means via optic nerve they can spread, and hemat means to the bones and the liver through skull and long bones. So coming to the staging, this is very important topic. It is by ICRB, that is International Classification of Retinoblastoma. So the staging, according to them, there can be group A, group B, group C, group D and group E. So coming to group A, they are very low risk tumor. Here the tumor is small size, less than 3 mm, and they will be confined to the retina and they will be far from the fovea, more than 3 mm from the fovea, and they will be also far from the optic disc, that is more than 1.5 mm. Now coming to group B, which is exactly opposite to group A. Here the tumors are large, more than 3 mm, and they can be any size near the fovea. So say they should be near to the fovea and near to the optic disc, while they are far from the fovea and far from the optic disc and are less than 3 mm. Here they have to be more than 3 mm. Coming to group C, here we can see focal seeds. So these seeding can be subretinal or vitreous seeds, and these seeds should be less than 3 mm from the tumor. Here it was from fovea and disc, but here it should be from the tumor. And group D means there is diffuse seeds, and these seeds will be more than 3 mm from the tumor. Now coming to the group E, which is very high risk. It is an extensive disease. It can touch the lens, and there can be neovascular glaucoma, anterior segment involvement, massive vitreous hemorrhage, orbital cellulitis, invasion beyond the eyeball to the optic nerve choroid, and there can also be phthisis bulbi. Coming to the investigation, first we have to do examination under anesthesia, that is the fundus examination. Look for the tumor size, location, vitreous seeds, IOP and corneal diameter. And then we have to do the USD, that is the B scan, to detect the mass and to identify the highly specific intratumoral calcification. We can also take CT to detect the calcification, and then MRI is used to evaluate the optic nerve invasion, intracranial extension, and to avoid the risk of radiation in children with germline mutation. We can also do genetic testing to identify the germline mutation, that is the mutation to RB1 tumor suppressor gene. Now, biopsy is contraindicated due to the extraocular seeding. Now, the most important part, that is management. So here the priority is saving the life more than saving the vision. So the treatment is according to ICRB grouping that we already studied as A to E. So first one is conservative therapy, and the conservative therapy is for group A to D, that is very low risk, moderate risk, high risk. So from group A to D we will give conservative therapy. What is conservative therapy? It is chemo reduction with focal therapy. So chemo reduction means we have to give CVE regimen. What is CVE? Carboplatin, vincristine, etoposide. So while giving this chemo reduction, they will shrink the tumor, and it is known as chemo reduction. So we are reducing the tumor by the CVE regimen. Now what is the next step? Focal therapy. So focal therapy can be given by cryotherapy, laser photocoagulation, or transpupillary thermotherapy. So it can be thermal, it can be laser, and it can be cryo. So this will cause the tumor destruction. So first we have to shrink the tumor, then we have to distract the tumor. Now coming to second thing, that is enucleation. So this we will do for advanced intraocular disease, that is group E with very high risk. So here we will do enucleation only if there is no potential for the vision, and also if there is neovascular glaucoma, anterior segment involvement, or massive vitreous hemorrhage. So what is enucleation? We are excising, that is excision of the eyeball with long stump of optic nerve. So we have to take the optic nerve with length of at least 10 to 15 millimeter. So why is this done? To ensure the complete removal of the tumor. Now comes the third thing, that is external beam radiotherapy. So we will do external beam radiotherapy for recurrent and diffuse diseases. So giving external beam radiotherapy has a risk of radiation induced secondary tumor and orbital hypoplasia. So we will do only for recurrent and diffuse diseases. Now last one, palliative therapy if the extraocular metastasis is present. So if there is extraocular metastasis, now we will give high dose chemo and radiation. So this was all about the treatment. First treatment is according to the ICRB classification. Conservative therapy for A to D, enucleation for group E, external beam radiotherapy for recurrent ones, and if it is extraocular metastatic, we will do the palliative therapy. So this was all about retinoblastoma. And do you want the whole notes of retinoblastoma? If you want the complete notes, you can check the Telegram channel. Link is given in the comment section. Thank you.